From the Veterans Administration in Milwaukee, Wisconsin, Kathryn Havens.
Hi, my name is Kate Havens, and I am the Physician Director of the Zablocki VA Women's Health Center in Milwaukee, Wisconsin. I want to tell you a story about how a small idea improved care for our women veterans. But I need to give you a little bit of background. HIV prevention, treatment, and quality of life have changed dramatically in the past 30 years. In the 80s, it was seen as a fatal, ravaging disease of healthy young immune systems. In the 90s, people with HIV were treated with handfuls of pills every day. Many died in spite of these treatment efforts. HIV now could be treated with 1 pill a day, and if detected early, could be treated as a chronic disease. Medical experts now believe that a 30-year-old with treated HIV can live as long as her counterpart who is obese and smokes a pack of cigarettes a day. With treatment, a mother with HIV can diminish transmission of this virus completely to her babies and loved ones and live a long and healthy life. The VA screens 87% of all of our veterans for cholesterol, 68% for blood sugars. For women, we screen less than 20% for HIV. When surveyed nationally, 73% of our veterans said they would be very likely to get the HIV test if their doctor recommended it. However, only 9% reported ever having been asked. So when I checked our data in Milwaukee, only a handful of women again had been screened in the past 3 years. I know the VA is the #1 provider of healthcare for HIV in this country. I also know that VA women seeking health services across the country has nearly doubled, and half of those young women are active duty young women veterans. We needed to do better. So it was time to bring in the troops. So our PAC team, design researchers from the Institute of Design in Chicago, our hospital infection nurses, and community advocates all put our heart and heads together. We educated ourselves about HIV testing, treatment, and prevention. Every person was qualified to answer any question. So why weren't we screening for this chronic disease like we do for others? We noted our own fears and assumptions about HIV. And of course, we needed to educate the patients, right? That was the issue. Our design colleagues suggested that we interview my fellow physicians instead, and we discovered an amazing story. We all know doctors are busy, and to explore the history of sexual partners and drug use included a dreaded and uncomfortable conversation. Who had time to ask all the sex, drug, and rock and roll questions to determine if a patient was really at risk? And here is the surprise. The average age of our doctors was 57. We were the cohort of residents in the 80s who saw young, healthy men die in our hospitals on our watch. Over the following decades, HIV patients had evolving and complicated drug treatment regimens and were cared for mostly in specialty clinic. The truth? We had little experience in the care of these patients. And how do we know who's at risk? There are known risk factors, but a third of the time, a woman with HIV doesn't fit the profile. A woman knows her own story, but not necessarily that of her partner, and especially if the risk exposure occurred years in the past. So to increase the number of HIV tests, the design students realized that the solution did not lie with the doctors. They wondered instead why the test couldn't just be ordered like any other. When the LPN first meets with the patient for blood draws and pressures, why couldn't they just ask about an HIV test? Turns out they can. So we implemented a pilot study. Each woman who visited the clinic was simply asked, do you want an HIV test? If yes, the LPN alerted the provider to order the test. And to our surprise, women overwhelmingly said yes. In just 4 months, we tested over 400 women. No judgment, no questions, just, would you like the test? So during that time, we shifted the power of ask to our LPNs and the decision to our patients. Our providers were absolutely delighted to improve screening. Our patients appreciated knowing their HIV status, and they were encouraged by the open conversation that occurred with any and all of their healthcare team members. We solved a problem, and this is the power of human-centered design. The design team with their fresh eyes saw what was right in front of us. Their insights fueled our innovation. We discovered that patients wanted testing, no one knows who's at risk, and doctors' time was now productively used to care for those very few women who were HIV positive. The best part of this story for us and for me is that your team can do this too. Working with AlphaChimp, we created a 6-minute video and a toolkit with support from the Office of Public Health and the Women Veterans Health Care Group. This kit has now been diffused across the country in VA women's clinics like our own. And that's my story. Thanks for listening.